If we can start this afternoon session. I love it, thank you. Okay, wonderful. We have all our speakers for this session, which looks very good. It's the oral abstract session on enhanced case finding and contact tracing. I'm Liz Corbett with London School of Hygiene and Tropical Medicine, and my close colleague here, Rita Lodlo, who I know well from Zimbabwe with the union. So if I can ask the speakers please to stick to time. Can I ask everyone in the room to turn off their cell phone sound, and we'll try to stick to time. So if you go over time, we may have to cut down on the number of questions. And can I ask all speakers, because this session's being recorded, so can all speakers and questioners please use the microphones? Okay. So our first speaker is Carly Rodriguez, who is a research assistant with Harvard Medical School. Go ahead.
All right. Good afternoon, everyone. I will be presenting on a review of national policies for TB contact investigation. So the World Health Organization estimated that 40% of people who fell sick with TB in 2015 were either undiagnosed or diagnosed but not reported. Contact investigation is a method of active case finding in which contacts of TB patients are systematically screened and clinically evaluated for TB infection and disease. And contact investigation is a WHO recommended intervention that can be implemented even in low and middle income countries. However, these global recommendations are just recommendations, and country level policies are actually set by national guidelines. So we conducted a review of national guidelines in an effort to identify policy gaps for TB contact investigation. So we began with a list of 216 countries who reported data to WHO in 2014. We conducted a systematic internet search using standard search terms and by searching National TB Program and Ministry of Health websites to find general or contact investigation specific TB guidelines. Our search was conducted in English, Spanish, and French, dependent on the language of the country, and in English when one of the official languages of the country was not English, Spanish, or French. We found guidelines for 58 countries through this method. We then contacted the National TB Program and in some cases our personal contacts to obtain a guideline when we did not find a guideline or found a guideline that was published before 2010. And we received or retained guidelines for 41 countries through this method, making a total of 87 countries for which a guideline was found. Finally, after language exclusions, we included 68 countries in our review, and we used a standard data collection form and double abstracted all guidelines. So we acquired guidelines for 50% of the 30 high burden TB countries. The 30 high burden TB countries represent 84% of the global TB burden, and we found guidelines for 43% of the 30 high burden MDR-TB countries. We achieved greatest coverage of the WHO regions of Africa, the Americas, Southeast Asia, and the Western Pacific, and less representation from Europe and the Eastern Mediterranean WHO regions. And our search yielded a fairly even distribution of countries' economic classifications amongst the 4 World Bank economic groups. So of the 68 countries included in our search, all countries had policies on TB contact investigation. For 44% of these countries, the guidelines said that the health system was responsible for contact investigation, and this meant either by a home visit by a healthcare worker or a phone call from a healthcare worker to schedule an evaluation of contacts. 7% indicated that the patient was responsible for contact investigation, meaning that the index case was instructed to bring or send their contacts for evaluation. And 41% of countries did not have a policy specifying this. 34% of countries recommended evaluating all exposed persons. 29% recommended investigating all close contacts, which includes household and close non-household contacts. And 18% of countries did not extend a contact investigation outside of the home. So for treating contacts who were exposed to TB, all countries in our review recommended preventive therapy for at least some contacts in which active disease had been ruled out. In 31% of countries, all contacts were eligible for preventive therapy, contingent in many cases on a positive TST. In 68%, only a subset of contacts were eligible for preventive therapy, with many countries restricting provision only to young children around the age of 5. And 29 countries provided treatment to varying combinations of children, people living with HIV, and those with other medical risk factors such as diabetes and silicosis. This group, it represents a heterogeneous group that's comprised of a lot of different combinations of those three characteristics, being HIV, a child, and other medical risk factors. So provision of preventive therapy among people living with HIV, specifically in the context of contact investigation, was lacking. 41% of countries did not have a recommendation for preventive therapy in all contacts with HIV. So in other words, while a guideline may have generally recommended isoniazid prophylaxis for people living with HIV, many guidelines did not explicitly recommend initiating preventive therapy after a known exposure to a TB case. So we also looked at policies for managing contacts of patients with MDR-TB. Half of the countries in our review included, or 78% of countries included in our review had distinct recommendations for contacts of MDR-TB patients, including all of the 30 hybrid and MDR-TB countries that were included in our study. Half of the countries in our review included a recommendation for prioritizing MDR-TB contacts for DST or other testing. And most countries recommended immediate initiation of a regimen effective against DRTB for those who are found to have active TB. However, 2 countries specifically described initiating first-line therapy in contacts of MDR-TB patients until a result from a DST was obtained. For contacts in which TB disease has been ruled out, 45% of countries provided guidance to not provide preventive therapy, and 6 countries recommended an alternate preventive therapy regimen in contacts of DRTB or MDR-TB. These included 3 countries who recommended a fluoroquinolone-based regimen for contacts of MDR-TB, and 3 countries who recommended an alternate regimen for contacts of INH monoresistance. And this was one of the few instances where countries provided guidance for contacts of monoresistant TB. So it is encouraging that every guideline that we reviewed included policies for TB contact investigation. However, we did identify some policy gaps that warrant consideration. First, almost half of countries did not provide a policy on how contacts are entering the health system for evaluation, and if responsibility is not clearly designated, it can be hard to ensure accountability that this is being performed. Second, the provision of preventive therapy in young child contacts was unanimous among countries, which appropriately acknowledges the susceptibility of this group to developing TB upon exposure. However, it is concerning that almost 40% of countries did not recommend preventive therapy for adult contacts with HIV. This means that some people with HIV who had previously received IPT might not get it after a new known exposure. And lastly, there's little international guidance about what to do with contacts of MDR-TB. And there's a lot of debate around whether these contacts should be provided preventive therapy. There's clinical trials in the works for this, but results from these trials are likely not to be available for some time. And a body of observational evidence exists that fluoroquinolone-based regimens can be effective in preventing TB in MDR-TB contacts. So it's encouraging to see that 3 countries have already included these in their guidelines. So our study did have some limitations. First, we only searched for and included guidelines in English, Spanish, and French, and this may have contributed to the underrepresentation of the European and Eastern Mediterranean regions due to our language exclusions. And second, and inherent to any systematic review, is the risk of missing data sources. And in this case, we likely missed other guidelines that supplement the general national TB guidelines, such as guidelines for children or guidelines specifically for MDR-TB. So it may have led to understating some policies for countries. And the question that remains and warrants future investigation is the extent to which these policies are implemented and practiced both on national and global levels. Thank you.
Thank you very much. We have time for one quick question, if there is one. Okay.
Hi, Peter McPherson from University of Liverpool. Thank you. That's a great review. I'm just wondering if you look systematically at the definitions of exposure that were included in the national guidelines and whether there was any sort of range in how exposure to TB was defined.
Mm-hmm. So that is not something that we abstracted from the guidelines because this differed so much across the guidelines. That's not something that I can answer for sure, but there was quite a bit of variation on that definition. All right.
Okay. Thank you very much. Our next speaker is Lorette Lawson, who's a professor of tropical clinical medicine at Brigham University in Nigeria and also the chair of the Nigerian Stop TB partnership.
Well, it's obvious that the limited healthcare access had contributed a lot to the missed cases we have all talked about. Over 1/3 of the 9.5 million people that are seen yearly are missed. This can be due to the fact that healthcare services are concentrated mostly in urban cities, whereas the slums and the rural areas and everything have very few centers. So we want to look at the limited data comparing profile of TB patients in the communities to those identified at health facilities, because there's this debate that it's possible that those who are being seen in the community are the same sets of people who come to the health centers in the city. WHO also recommends a systematic screening of risk groups so that at least it's important that we should go into the community also. This will improve the universal health coverage and increase case detection, which in my country at the moment is very low. It's about 17%. This knowledge is very important to healthcare workers. Well, what are our objectives? To compare the profile of two very large groups with symptoms suggestive of TB. The first group were those comprised of adults prospectively screened when attending health centers. And the second group comprised of individuals as identified through screening in urban slum settlements by community health workers who went from house to house recruiting or enrolling patients with cough of over 2 weeks. The methodology, 2 cohort adults with cough of 2 weeks enrolled from hospitals and households in urban slums in Abuja, in the FCT, that's the Federal Capital Territory, Nigeria. Participants were asked to provide sputum for smear microscopy, and the demographic and clinical information were collected. Differences were calculated by recruitment place and the smear status. That's smear positive, whether they were smear positive or smear negative, within and between the settings. Well, that is the result. I will summarize the important, if you look at it, well, over of the 4,070 patients that were enrolled, 1,202 were from the health facilities, and 2,868 were enrolled in the communities. The community, we found out that community participants were older and had more frequent and longer duration of symptoms. But those were just the participants. But 17.4% of participants in the health facility were smear positive, and 405 were in the health centers. 209 in the health centers, 17.4 were positive, and we found 16.9% in the community. Sorry, that is missing there. We found also, when we compared both, we found that community participants were older, they had longer cough duration, and had more weight loss, duration in weight loss. They complained more of fever, chest pains, and anorexia, comparing the community to those in the city, in the health centers. We now look within the various, within the community and within the health centers. And we found that within the community, we found smear-positive patients were younger, more likely to be male, more likely to complain of weight loss and anorexia. But there was no difference in symptoms duration by smear status. We looked at the facility-based population also, those in the health centers. Smear-positive patients were also younger, likely to be male, had longer duration of all symptoms, had higher frequency of fever, weight loss, and anorexia. We concluded that the patients in the community were actually different from cases attending health centers. That from the results we got. We also found that the patients identified in the community had more symptoms and longer duration of illness. This means that they have there and they have not been seen. They are not the same people going into the city to go for health, to complain at the health centers. So community-based activities targeted at urban slum population may identify cases not accessing stationary services and prevent transmission. These are, we've submitted a paper which has been accepted, what's in the press, and those are the authors. Thank you very much.
Thank you very much. Time for a couple of questions. Okay, can I just, okay, yep. Yeah.
Thank you for your presentation and big cohort.
Yeah.
Do you think it will be more effective with use of just this way, like WHO recommend for active case finding, and after when you have a smear negative and just this way positive, complete with by expert?
I'm sorry.
So the question was, would you have been more effective if you'd had the digital chest X-ray instead of relying on sputum examination?
Okay, thank you. Digital chest X-rays are not easily available in these settings. It's easier to do the smear, to do smear microscopy, where we are now actually using more of the GeneXpert for identification of patients, but then at the time, we have, you see, digital X-rays are very good, but they are also non-specific. Okay, they are also non-specific. So we're talking about identifying patients that are smear positive.
Quick question, quick answer, please.
Sure. Thank you for that very interesting presentation. Do you have any information on the treatment outcomes of the patients, since this is commonly a concern in patients found in more active versus the detected in the clinic?
I will confess that I didn't follow that up. We didn't follow that up.
Okay. Wonderful. Thank you.
Thank you.
Our next speaker is Leo Martinez, who's a PhD student with Georgia University. Thank you.
Thanks. So I'm going to talk about 2 household contact studies in Uganda and trying to find methods to optimize household contact tracing as an active case finding role programmatically. So these are just the authors and the collaborators. So our study our study objectives were to identify the most predictive variables for coprevalent tuberculosis disease amongst household contacts in Kampala, Uganda, from a large household contact study, and to estimate the number needed to screen to detect one coprevalent tuberculosis case after identifying the highest risk contacts with the most risky variables. And then to attempt to validate targeting these highest risk contacts using data from a separate study of household contacts from the same location. So this is just the general study design for the 2 studies that I'm going to be talking about, and they had the same study design. So index cases were recruited from clinics, self-reporting, and then they were asked about their household contacts, and all households were visited and all contacts were given demographic characteristics, demographic questionnaires, and evaluated with a tuberculin skin test, and also evaluated for coprevalent disease. The COEMPE study also evaluated incident disease, but the goal of this study is just to target coprevalent disease and to evaluate it as an active case finding. And so these are the 2 studies, COEMPE Community Health Study and what's called COSANET. It's a currently ongoing household contact study. They're still recruiting. Okay, so this is the same slide, but just some numbers to go with it. So there was almost 500 TB index cases in the COEMPE Community Health Study with a little bit less than 2,000 contacts. And we found a little bit over 80 coprevalent active TB cases, so a little bit more than 4%. And in COSANET, there are 124 TB index cases with 530 household contacts, and so far there's 17 coprevalent active TB cases. Since it's ongoing, we should get some more at some point. And a little bit more than 3% coprevalent disease amongst contacts. So this is a little bit busy, but I'm going to walk you through it a little bit. So these were the most predictive variables in the derivation cohort. So this is the COEMPE Community Health Study. There's a lot of variables in the background that I didn't include because this is already a pretty busy slide. But we found that the most predictive variables were chronic cough. So that's cough for 2 weeks or more. If a contact shared a bed with an index case, let's see if this, oops. So if you shared a bed with an index case, you had 7% chance of coprevalent disease. If you had chronic cough, it was 20%. If you had past tuberculosis disease, these were self-reported and low numbers, but you had over 11% risk. Also, if you were contacted and you had HIV yourself, you were at 11% risk versus 3.8% risk. If the index case had lung cavitary disease, is over 5% risk of co-prevalent disease. And I included smear status here, but the contacts exposed to sputum smear positive cases were not a statistically higher risk. And so if you look on the right-hand side, you can see the odds ratios. The most predictive variable, although all these are fairly predictive except for smear status, the most predictive variable is chronic cough over 2 weeks, which is not surprising, but I guess the magnitude is maybe a little surprising. And I just want to say this is not adjusted just because we wanted to find the most predictive variables in this univariate model. And so then I calculated the number needed to screen to detect one co-prevalent case using these most predictive variables. So low numbers are better, so less contacts you need to screen to detect one case would make contact tracing as active case finding more efficient. And so, not surprising, this matches well with the spectrum of odds ratios we found. So if contact had chronic cough, we only needed to detect 5 household contacts to detect one case. So very high yield of disease. Some of the other risk factors that we analyzed also had a very high risk of disease also. So HIV seropositive contacts, only 14 contacts needed to be evaluated to find one case. And so this is a little bit of the results. It's an ongoing analysis, but a little bit of the results from the validation cohort and using so I guess I didn't write it here, but we only used chronic cough contacts, so how sensitive, specific, and the PPV and MPV, if we only screened household contacts that had chronic cough for 2 weeks or more. And to see how it did in the Coimpe Community Health Study, and then also how it did in the validation cohort in COSANET study in the same place. And we found similar results. So the sensitivity of only screening household contacts with chronic cough for coprevalent disease was 77% in the derivation cohort and then 71% in the COSANET cohort. Specificity was 84% in Coimpe study and 91% in the COSANET study. PPV was 21 for both studies, and 99% was the NPV for both studies as well. So in general, it validated fairly well. So, household contact tracing as an active case finding method programmatically is not implemented very often, and especially in high burden settings. So it's possible identifying only contacts that report chronic cough may make more incentive for these programs to implement it. So in high burden settings such as sub-Saharan Africa, contact tracing may be useful as a supplementary tool to current TB control. And so these are just all my collaborators. It's a very large 2 projects that I was lucky enough to work on. So thank you.
Very nice data. And 2 questions. Do you want to use the microphone? Sorry, and please introduce yourself quickly.
Okay, I'm Cam from Nigeria. Thank you very much for your presentation. Thanks. I actually have a lot of interest in contact tracing, but I think I'm more curious about the slide in which you showed the possibility of the number of cases you could detect from the groups of persons you screen, specifically for the sputum index cases, of which you said 200, which I would beg to differ. So which pegs me to ask this question: what methods of screening, contact screening was implemented? Was it a situation where you requested for the index cases to come with the contacts to the facility, or you had to go to the homes of these? Because there is a huge difference in that,
no, definitely,
especially in our settings. Thank you.
Yeah, so that's a good question. And so both of these were research studies, so we actually went to the household and screened everyone there. And I agree, it would be very different if we asked contacts to come in. We might get differential, like follow-up and differential contacts. And so, yeah, so basically we went to all households. is, I guess, the answer.
One last quick question, quick answer, please. Thank you.
Hi, my name is Miriam Bakker from KIT. Thank you for this presentation. I'm a bit confused with your conclusion. You say you could focus on those with a cough, but I'm a bit confused. Wouldn't that always be the first question anyway to ask if someone is coughing? So I'm not sure, were you doing the diagnostics for all contacts or only for those who were coughing?
So I think potentially there needs to be a little bit more research about it, but potentially you could only go to households that report chronic cough in the household. So right now, it's not as clear whether you screen all household contacts for active case finding or some, I guess.
But Lee, I think the question was, you yourself, in this study, everyone was rigorously screened.
So everyone was screened, everyone was given chest x-rays, evaluated for TB, yeah. And so this is just evaluating which variables, yeah.
Prefer to, your recommendation is to limit chest x-ray for those who are coughing?
Yeah, just evaluate the contacts that are coughing. Yeah, exactly. Yeah, but this also needs to be validated like programmatically. So these are research studies.
No, but a nice study and very interesting suggestion, I think.
Thank you.
We better move on, but thank you very much for that. So our next speaker is Kopto Kora, who's a medical epidemiologist with the Union in Paris.
So the subject of my presentation is about active case finding project and tuberculosis TB cases notified at national level. So many people with tuberculosis remain undiagnosed. So in 2013, WHO estimated that 37 TB cases were not diagnosed. So active case finding project, ACF, is one of the several interventions which has been developed over the last 2 decades with one objective to increase notified TB cases of all forms of TB. So ACF projects are often implemented in local area. To our knowledge, its impact of ACF project on the TB cases notified at the national level has not yet been documented. So the goal of this study was to analyze the impact of ACF project on the number of sputum smear positive, SS+, TB cases notified at national level. To achieve this goal, we selected the wave 1 of TB Reach project. During this wave 1, 30 projects were implemented from 2010 to 2012 in 19 countries. So we excluded Burkina Faso, Yemen, and Sudan. Our analysis was performed on 16 countries. What about data collection? We used TB Reach, the Creswell publication about the wave results of wave 1. And for SS+ TB cases, we use a WHO Global Tuberculosis Report. Our statistical analysis was performed in 2 steps. First, we describe the results of TB Reach project, and in the second step, we analyzed the trend of SS+ from 2005 to 2013. The yearly notifications are not independent, so probably the potential serial correlation of the data, and we use a segmented linear regression. So the equation is written below, and we use beta 1, beta 2, and beta 3 to describe the trend of TB cases before the intervention, during the intervention, and after the intervention, respectively. What about the result? So for the first step, when we use TB Reach, the publication of the results of TB Reach, increase from 3% to 334% was described in 14 countries. And only in Rwanda and Nepal, we have a decrease. After TB enrichment, we use the segmented linear regression using the coefficient beta. After a TB-rich project, there were an increase in 9 countries and a decrease in 7 countries. During TB-rich project, there were no significant increase in almost all the countries except in Benin and Kenya. And then after TB-rich project, there were no significant increase in almost the increase of SS plus TB cases at national level in almost all the countries except in Somalia. Here, this figure, shows the trend of SS plus TB cases at national level in 10 countries. In these countries where TB-rich was performed, they describe an increase greater than 10% in the local area. So, as you can see, the trend of SS plus the trend of SS plus trend seems to be stable during the TB-rich intervention. So, this is the first study which explores the impact of ACF project on the TB cases notified at national level, and not only in the area of the intervention. So we use a segmented linear regression, and this method allows adjusting for potential correlation of the data and provides a better interpretation trend of SS plus TB cases. So we know there are several factors which could explain the trend of TB cases at national level, but these factors were not analyzed because they are beyond the scope of the study. So what about the interpretation of our result? During the first step, we showed that TB-rich project in the areas of the intervention, we found an increase in SS plus TB cases in almost all countries. Many other active case finding projects describe the same results. That is the case of Fidelis, for example. So we assume that this local increase is directly related to these active case finding activities. So during the project, in almost the countries, we found that no significant increase except in Kenya and Benin. In Kenya, this increase could not be attributed to ACF due to the low additional cases. In Benin, in contrast, this increase can probably be attributed to ACF because the project was performed all over the country. So what about the trend of SS plus after the project? There were no significant increase in almost all the countries except in Somalia. But you know, Somalia, this increase, it's not obvious to attribute this increase to ACF. There are permanent war in this country, and during the intervention, the change was not significant. So to conclude, ACF project had no impact on the case notified at national level during the intervention in almost all the countries during the intervention and after the intervention. So ACF projects are pilot studies and are usually not reproducible at the national level due probably to the high cost and the lack of human resource. So this finding challenges the usefulness of ACF strategy to find the undiagnosed TB cases. Thank you for your attention.
Yeah, one quick, it's controversial, so what does one question and one short answer?
I just wanted to make a comment. Professor Lawson is talking next, and his project in Nigeria was one state in 38 states in Nigeria. So although he doubled the case notification, if you wanted to see in one state influencing the whole national trends, it would be really realistic. Yeah? So, and nobody would have expected that. And the second is that as a result of that, the national program for Nigeria decided to implement the same activity in 10 mega slums in the city. So we are learning in this process. We don't know if that's going to increase the case notification, but at least we are trying. And I think to say that this is not scalable is a little bit premature. So it is funded by the Global Fund, and it is happening. So we just have to see what happens.
Yeah.
Okay.
Yeah,
Thank you for your comment.
I would just say that I think many of us agree with what Louis said. Just it's a bit of a big ask, isn't it, to have a scale up that quickly. But thank you very much for the presentation, and I think it's an interesting analysis that does need to be taken forward as we go forward. Thank you.
Thank you.
Thank you very much. Our next speaker is Marco Tovar, who is a pediatrician and research coordinator from IFHAD in Lima, Peru.
Thank you, the organizer, for this opportunity to talk part of the work that the IFHAD research team is doing in Peru. I apologize for my English. It's not perfect. I try to explain my ideas in this imperfect English. Okay, we know that many TB cases are missing, and the question is how we are going to discover these missing cases. And we did this study. We did this study in the TB-affected household. That means that all of the household, in all of these households, there was a TB case previous our study. Okay, all of these patients. Where is the point? Yeah, all of these patients were recruited since 2002, 2011. For this proposal of the prevalence survey, we exclude all of the patients less than 8 years old because it's difficult to obtain a spotted sample or at least saliva. Okay, all of these patients were eligible for our follow-up 2 years after the patients finished it, the first patient in the household finished the therapy. Okay, unfortunately, we couldn't screen all of these patients, and this is the population that we could screening with a smear microscopy and a simple technique of culture in a culture of sin layer agar. This is our results. We interviewed all of these participants in this household with a questionnaire, and we took the sample independently if they have symptoms or not. And we defined 4 groups. I excluded the group that was on treatment when we visited the house. We had 89 participants that were on treatment during the visit. And I'm maintaining here these 3 groups. Groups that had cough more than the 14 years. Another group that had cough but not less than the 14 years. And this group that they don't have cough, asymptomatic. And we can see here the result of the smear positive. Obviously, I think that we all here expected that we have more positivity in these 2 tests for the group with cough for more than 14 years. But you can see we have more, in the absolute number, more culture positives in the group asymptomatic. Obviously, we present this in percentage, the percentage is less. And we can see here in the number needed to screen, like in previous presentation, the cough is a good strategy to look for the TB cases. But the big question for all is how we are going to discover these other cases. For that, we try to discover what factors were associated with all of these culture positive. We have here 47 culture positive. This was all the factors associated with univariate regression. The pure people has more chance to have a culture positive. If you have previous TB, you have more chance to have a positive. If you have a non-MDR-TB exposure at home, is a factor associated. History of incarceration, diabetes, so reported, not with tests, self-reported, drug abuser, alcohol abuser, and cigarette consumption. But when we did the multivariate regression, this only for 4 factors maintain this significance. The pure, here. The people, the people pure, the people with non-MDR-TB exposure, history of incarceration, and diabetes. This is the 4 factors associated after the multivariate regression. And obviously, one form to try to decide if we could do active case finding in this group is the number needed to screen, and this is the comparison. This is the group participant with the presence of one of these risk factors, and this is the group that don't have the presence of these factors. And you can see that if you belong to the group of people that are in the lowest tercile of the poverty, you need to do only 94 culture to obtain 1 culture positive. If you have a non-MDR-TB exposure, you need to do only 45 culture to obtain 1 positive. If you have history of incarceration, you need to do only 21. And if you suffer of diabetes, you need to do only 41 to obtain 1 culture positive. So our conclusions are that the prevalence survey in this group identified many undetected TB cases. And most prevalent TB cases did not know they have TB, did not have systems that usually qualify for TB testing, that in most of the country maybe is the cough for more than 14 years, would have been missed by standard microscopy testing. And the other is the targeting activity screening could be useful to identify undetected TB case in this some vulnerable group. I acknowledge to this wonderful woman, worked very hard in Ventanilla, and all of the IFAD group in Peru, and obviously the founder of this project. Thank you very much.
Thank you. Can we have 2 quick questions? If there's nobody asking a question, perhaps I can. Over to you.
Oh, thank you. Thank you for a great presentation. I'm Neil Martinson from Johannesburg. I'm just wondering if you really want to have an impact on TB, whether those people, the culture positive, are really the ones that you would like to get hold of, because they are unlikely to be diagnosed under normal circumstances, where the other ones with symptoms are going to present themselves at some stage.
Sorry. If someone could repeat this slow.
Yeah. So the question was, shouldn't you be shouldn't you be focusing on the people without the symptoms, not the people who do have the symptoms?
Yeah, we did not present here, but in the analysis only of the people without symptoms, one of the factors associated for this was history of incarceration and diabetes. But we have a little positive number to compare. We are going to screen more patients in a future prevalence survey in 2 years in Peru with approximately the double of the sample.
I will translate afterwards. Si no tenían tos, ¿cuáles eran los síntomas que predecían que tuvieran cultivo positivo? If they didn't have cough, what was the symptoms that predicted to have a positive culture?
Thank you very much for speaking English.
It was Spanish, actually.
No, I know. I speak Spanish. Maybe I need to answer in Spanish first and then in English.
I will translate. Yo traduzco.
Gracias por traducir, entonces. Okay. Some of the symptoms that we asked in this questionnaire were weight loss and sweat night
sweats.
Night sweats. Thank you. Night sweats. Weight loss, night sweats, and fever. But none of these symptoms were related or were associated with this culture positive.
Okay, thank you very much.
Thank you.
Our next presenter is Dr. Lena Shah from McGill University in Canada.
Oh, sorry.
Oh,
it's actually
sorry. Beg your pardon.
It's
Matt Saunders.
Yeah,
beg your pardon. So you'll come after Matt Saunders, who is from Imperial College, London. Over to you.
Thank you. Thank you very much for giving me the opportunity to present today. I'd like to just echo what Mark has just said and thank and acknowledge the IFAD research team in Peru, these wonderful nurses and data managers and laboratory team. I've joined this project relatively late and I wouldn't be able to present these data if it wasn't for their hard work over the last 15 years. So I'm going to be talking about predicting TB disease among adult household contacts. So as we've heard today, contact investigation and TB preventive therapy, it's well recognized that those are essential interventions and essential components of the end TB strategy. It's also, I think, quite well recognized that these interventions are rarely prioritized by national TB programs that are often, particularly in resource-constrained settings, overwhelmed with the sheer number of patients they have to diagnose and treat. And I think that's particularly true for adult contacts who often aren't included in policies for preventive therapy. I think this is exacerbated by the fact that preventive therapy prescriptions are often guided by tests for latent TB infections, such as TST, which have got a number of known logistical and technical challenges, not least that in these high-burden settings, their ability to actually predict who develops disease is severely limited. Their positive predictive value is quite low for identifying which contacts actually develop disease. So in this study, we tried to think about things in a slightly different way. And we aim to derive and validate a TB risk prediction score for contacts over the age of 15 years of patients who were living with TB, using index case, contact, and household risk factors for TB disease that could be readily collected at the time of contact investigation. And we aim to develop a score that could be used without testing for TB infection. Currently in Peru, there's a shortage of TST, and contacts often don't receive it. So we performed a prospective cohort study in Ventanilla in Peru. Ventanilla is the name given to a collection of peri-urban shanty towns in the north of the city. We first identified index cases who had laboratory-confirmed pulmonary TB. We then visited their households and invited their household contacts to participate in the study. So household contacts completed a detailed questionnaire characterizing TB risk factors. We measured and weighed them and calculated their BMI, and we offered them baseline tuberculin skin testing as well. So in total, we recruited 2,017 contacts. We subsequently followed contacts up for a median of 11 years, ascertaining TB disease diagnoses using national TB program records and also our own active follow-up about once every 3 years. So in total, during the study period, 178 contacts out of the 2017 developed TB. So that equates to an incidence of 0.93 per 100 person years. So you can see in this graph here, on the vertical axis, you've got incidence of TB. There's a laser. No. You've got incidence of TB here, and then we've got time from exposure. And there are two lines. So the gray line here, this is the actual incidence of TB in the contacts. And the black line is the actual notification rate in Bentonilla during the study period, which we adjusted by 20% to take into account that there had been a number of cases diagnosed and treated outside of the TB program. So you can see there are two messages that I think are important in this graph. Number one is that much of the TB in contacts occurred early, as we would expect. So the incidence here early on is extremely high, 2,500 per 100,000 people in the first year. And also the incidence of TB in contacts remains significantly higher than the notification rate in Bentonilla for at least 10 years. So subsequently, we used Cox regression to identify factors that were associated with TB disease and to derive our risk score. So in our multivariable Cox regression model that was also adjusted for household clustering, we identified 9 risk factors that were significantly associated with incident TB disease in these contacts. So these were body mass index, which was linearly associated with TB disease, having a history of previous TB, being aged 15 to 19 or over the age of 50, having had prolonged exposure to the index case prior to the index case being diagnosed, having been exposed to a male index case, being from a household that was from a lower household socioeconomic position, having been exposed to indoor air pollution if the household cooked with certain cooking fuels, if you lived in a household where any of your other household members has also previously had TB, that increased your risk, and if you lived in a household that had a lower window to room ratio, which is a marker of ventilation. So from the regression coefficients, which we use as our weighting in our risk equation, we derived an integer-based risk score because we wanted to develop a risk score that could be used easily in the field without having to use a calculator. So basically, these points correspond to these regression coefficients having multiplied by a constant. So that translates nicely into this simple pro forma, which we envisaged could be used by a community health worker at the time of a home visit. And basically what happens is that you start with the contact BMI, which you can just use a simple chart to derive BMI. And then subsequently the nurse, whilst interviewing the contact, would ask each of these questions and subtract a number of points depending on whether or not the risk factors are present or not. And at the end, each contact has a grand total number of points. So we applied this score to all 2017 contacts in our cohort and derived 3 risk groups: a low risk group, which 30% of the contacts fell into the low risk group, a medium risk group, and 44% of contacts fell into the medium risk group, and a high risk group, and 27% fell into the high risk group. They were arbitrarily defined, really, in order that we could so that we could present differences in the risk. Really, this is a continuous spectrum. As your score decreases, your risk increases. So how does this actually correspond with risk of disease? So what you can see here on the vertical axis is the cumulative risk of tuberculosis disease. On the horizontal axis, we have 4 different time points, so 1-year risk, 2-year risk, 5-year risk, and 10-year risk. And if we just focus on the cluster of columns here, this grey shaded column is the risk of TB disease in Bentonilla, if you live in Bentonilla as a resident of Bentonilla, so your background risk. And then we've got the low risk group, which is the green, medium risk group, which is the orange, and the high risk group, which is the red. And you can quite clearly see the stark and important differences in risk of TB disease depending on which risk group you fell into. With at 10 years, if you were in the high risk group, 21% of those contacts developed TB disease. The C statistic for our model, which is basically a marker of discriminative ability, how well our model differentiated between people who developed TB and who didn't, was 0.72, which indicates good predictive ability. I haven't got time to talk about how we internally validated the model, but if you'd like to know about that, you can find me afterwards. But our internal validation procedures showed that our model was robust. So subsequently, we wanted to try and illustrate how this could be used and how this might impact on practice, on how doctors prescribe preventive therapy and on how contacts consider their own risk. So we calculated the number needed to treat with preventive therapy to prevent 1 TB case from occurring over 10 years, assuming that in our setting, isoniazid had an effectiveness of 90%. So in the low-risk group, where the observed 10-year risk was 3%, the number of contacts needed to treat would be 40. In the medium risk group, where the observed 10-year risk was 6.2%, the number needed to treat is 18. And you can see in the high risk group, where the observed 10-year risk was 21%, so 1 in 5, the number needed to treat was 5. So I think that nicely illustrates how this might be used to really target our resources to people who are at highest risk of falling sick. Now, as I said, we offered baseline TST testing to all of our participants. So I'm just going to briefly show you that our risk score works in each category of TST. So in TST negative people, we were able to stratify people by risk. In people who didn't have a result, which is the actual scenario for all of our contacts at the moment, we don't have a TST result. Our risk score effectively stratifies risk by risk, and in the TST positive group as well. And we also performed a sensitivity analysis where we included TST results in a risk score, and we didn't see any additional predictive benefit gained by actually including the TST in the risk score. So I've got 3 main messages as I come to my conclusion. First of all, I'd like to emphasize that the risk of TB among these adult contacts is extremely high, and it remains significantly higher than the general population for at least 10 years. Adult contacts are rarely prioritized, despite the fact they form a very large group, a very large population who are clearly at high risk. We have successfully derived and validated a risk score that effectively stratifies which contacts have got the highest risk of disease, and that risk score works independently of TST result. So we think that our risk score can be used to facilitate highly targeted TB screening, TB surveillance, and TB preventive therapy for people who are most likely to benefit. And that through that, we can reduce the number needed to treat and potentially improve the effectiveness and efficiency of contact investigation and preventive interventions in resource-constrained settings. So the next step with this is that we're evaluating it in a cluster of community randomized trial of socioeconomic support to prevent TB, actually visiting households, informing contacts of their risk, and trying to increase the number of people who take preventive therapy. And our outcome at the end of that will be whether or not we actually prevented TB disease in these contexts. So thank you very much. I'd like to just again thank all of my funders, the IFAD research team, and particularly my supervisor, Dr. Evans, who isn't here today, but who has given me the opportunity to work on this really exciting data set. So thank you very much.
Thank you very much. I would like to give my co-chair, Lise, a chance to ask a question for clarification, or point for clarification, and after that, one quick question.
Thank you. Chairman's prerogative. Can I quickly answer? Thanks a lot, Matt. That's very interesting data. I just quickly want to ask about the BMI.
Yes.
Because BMI says typically 20 to 30, in that range.
Yes.
So it's a large number compared to your other scores.
Yes.
Is that the BMI at the time
of
the index was diagnosed, or
yes.
is that?
Yeah, so we aim to recruit contacts within about a week of the index case being diagnosed. So that was the BMI at the time the index case was diagnosed, and it was a linear association. So if anyone's interested, there's a poster describing that association in more detail.
Thank you. One question, perhaps the gentleman at the back.
I think it's really amazing work, and
Thank you.
My question is, how far you think this system, this score, is applicable in different environments? Because I haven't seen, for example, such an important factor like HIV infection.
Yes, that's a very good question. Thank you. So in our setting, HIV prevalence is less than 0.5%. We're not including it in the risk score, but we're obviously, as part of our study, prioritising chemoprophylaxis for people who have got HIV. But I think that many of the risk factors, if you look at the risk factors that we've shown, they're transferable to other settings. And I think that potentially with validation, or not even validation, potentially at the moment people are getting nothing. I think potentially something like this could be used. And obviously with the proviso that people who have got HIV are prioritised completely separately. We've already heard of the importance of giving them TB preventive therapy. This is really for other people.
Thank you. Thank you very
Thanks.
much indeed. It's now my pleasure to ask Lina Shah to come forward. Sorry to alert you once earlier. And she's a postdoc student from McGill University in Canada. over to you.
Thank you. As mentioned, I'm from Canada, but and it's not a conspiracy. I'm also presenting data on Peru, so maybe we should just highlight that part. I'll be presenting some work that we've done on the cost effectiveness of active case finding, particularly focused on household contacts of TB patients in Lima, Peru. Obviously, I too am supported by many institutions and also many funders, who I'll mention at the end, but if you want to see all their emblems, of course, they were happy to share them with me. So the work that I'm presenting takes place in San Juan de Lurigancho district, which is one of the largest districts in Lima. It's one of the most densely populated areas. It's an urban area, and the TB rates there are quite high and higher than the national average. The national TB program is well established in this area. There are 34 health clinics through which they run the TB DOTS program. And generally, there are about between 1,800 and 2,000 cases notified per year. As Matthew mentioned, there are less than 3% HIV co-infection, so it's not really the main driver in this area. But one of the major challenges in Peru, and especially in this district, is the high rates of MDR-TB, of which a growing proportion are primary MDR-TB amongst new previously untreated cases. So MDR-TB emerges as an important consideration as well as the general number of TB cases. I think we're all interested in the same thing, active case finding, as are we in this setting. And obviously, there's an increased focus on the need to evaluate household contacts. There's WHO recommendations, as was mentioned earlier, that have emerged. And a lot of national TB programs also have guidelines. In Peru, they also have well-established household contact tracing guidelines at the national level, including 3-time evaluations of all household contacts, as well as the provision of preventive therapy. But in practice, it's not often done. If you go to the health centers, you'll find that while that is in part of their practice, it really doesn't happen very often, and not, if anything, not systematically and routinely. And it's something that even at the local level, people are concerned with. Overall, it's something that we're very interested in. There's also locally as well as nationally and internationally very limited existing data on the effectiveness and cost effectiveness, and in particular with respect to operational data. So from programs in the implementation side of having to do this within the NTP on the ground. When we talk about active case finding, obviously there's a wide range of activities, even here locally in Peru. There's things from door-to-door campaigns, different types of focused activities. In general, we're talking about provider-initiated activities. In this setting, we're talking about extramural activities, including home visits. And the work I'm presenting today focuses on specifically on household contacts of index TB cases enrolled in treatment. So broadly, our objectives were to compare the cost effectiveness of active case finding program for household contacts integrated within the NTP DOTS program locally, and comparing that to our routine passive case finding. We considered all pulmonary TB cases within the program and within national TB program in this district specifically. This is sort of a companion piece to a larger study we're doing in conjunction with the Ministry of Health in the district of San Juan de Lurigancho, trying to integrate active case finding for household contacts within their routine program. So I'm presenting the cost effectiveness piece, some of which has pieces through our direct measures, and some of which was supplemented with systematic review data on active case finding that we know is well published now. We tried to do a decision analytic model. I won't give you all the details of these complex trees, but generally speaking, we compared various arms of strategies to one another. Our baseline strategy was the routine TB program and self-report of symptomatic cases to care. And then we compared three other algorithms. One was provided-initiated active case finding program. We followed basically what would have been done by the national TB program and the local district program. So symptom screening, sputum smear evaluation, chest x-ray, and clinical evaluation is part of the contact screening endeavor. We also included a piece around home visits to seek out household contacts as part of our algorithm around active case finding estimates. And we focused mainly on the time of TB diagnosis when the index TB case came in and when a large proportion of the household contact activity would occur. So that's our active case finding program. In addition, we also considered, while not used routinely for household contact screening or in practice in this district, we considered the addition of expert. So what would happen if we included an expert test for a single sputum sample for household contacts within just a routine program for household contacts, and then also specifically with both of those activities, active case finding plus using the expert diagnostic test. A bit about the parameters. So if you know a little bit about cost-effective analysis, you're really seeking out some of the best estimates you can to be able to put into these various treatment arms. We were looking at an overall effect, looking at disability-adjusted life years. We did consider cases that were secondary cases detected, and once they were treated, their potential outcomes as well, looking at cure and completed and default and failure as our outcomes. And then when it came to all the probabilities that we inserted into the model, we looked through some of the basic epidemiology of TB, particularly around what we know so far about proportion of TB detected in household contacts. We looked a lot at systematic reviews around this and tried to include a range of potential values for that particular parameter. We also use published diagnostic test sensitivities around expert, also for sputum smear. We wanted to include some of the more standardized systematic review values, but within those as well, we use some ranges for values to use during our sensitivity analyses. What we also tried to do with our cost data was look specifically at what was happening locally. So cost of tests and treatment, some of those are sort of more widely known figures. We tried to use some of the cost of tests that were being used locally. And we also tried to get a direct measure of the actual active case finding time. One of the things that's been suggested to us in our district was, what some of the challenges around actually doing the active case finding, doing the home visits, and the time and effort and potentially resources required to do so. So we did, as part of our project in conjunction with the district, we tried to get an estimate of how long and how much time that was going to take. So we did estimate our salary costs, nurses and physicians, materials and operational costs. We also integrated within that the need for training, monitoring, and supervision of active case finding program, which is sometimes overlooked, and so we wanted to integrate that into our cost measures. So within our other projects, we had we took a random sample of the centers that we work. It was actually also done within a shorter period. So we had a 1 month period where we had some research teams accompany our program nurses in their activities and also ask them questions about how long things take with respect to the actual screening of the household contacts. So they are estimates, but they're better than what we've had in the past. So we tried to integrate these into the model. In terms of the incremental cost effectiveness ratios, those of you interested in this table might want to look at all the figures, but I'll just say that the active case finding alone resulted in a cost per DALY averted of about $1,800 US, and that obviously increased with the addition of expert and both of those strategies together, which was around $3,000 US per DALY averted. I think the key thing here, if we consider the gross national income, which is sometimes used as a threshold, that's in Peru is a middle income country, and so the GNI is around 6,000. So these fall within that range. Obviously, there are much more discussions around willingness to pay in practice and the investment in actually doing some of these activities, which is a broader discussion to be had. This sort of model that I'm presenting was around for 2,500 index cases, so around 10,000 household contacts. On average in this district, there are about 4 households per contact, per index case, but obviously that also ranges, and that can impact a lot of the type of cost effectiveness of such a strategy, and also feasibility. Obviously, major activity in these models is sensitivity analyses, and essentially we varied a lot of parameters over a range of values, some of which were estimated. We tried to be conservative here where we had good values, but otherwise we tried to be very broad to give us a real sense of what might happen. In general, the findings remain cost-effective when we're given changes to the increase of cost of active case finding, which I found somewhat surprising, and this also went up to 3 times the cost for active case finding, including the salary capillary times to be able to either go multiple times to the house to capture people who hadn't potentially been caught the first time or screened the first time. It also accounted for changes and increases in the time to undertake the contact investigation, test cost or sensitivity, and also the probability of the passive case finding system and ability to capture the household contacts. Obviously, if the passive case finding was performing so well in capturing all of the household contacts, then obviously this would no longer be cost effective. But before that, other than that, even varying that remained cost effective. The one big exception was around including active case finding with and without an expert test. This, when we varied the outcome of default and failure, that really had a huge impact on the remaining cost effectiveness of this model. And what that suggests to us was that we really, these active case finding strategies would be really well cost effective and worth the investment if we are going to assure that cases that are entering treatment are therefore still remaining with high positive outcomes such as cure and completion. If the default rates were then to go up, that would definitely impact the overall cost effectiveness of this model. So in conclusion, I think active case finding is under consideration in numerous low and middle income countries. We do need evidence, particularly from operational state data. I think systematic active case finding household contacts within programs could be cost effective, but obviously there are lots of limitations to these types of analyses. And in our case, we really looked at cross-sectional screening of household contacts at one time. We didn't look at follow-up over time or long-term impacts of that. We also looked at we had certain assumptions. So for example, we assumed that all cases would be entering treatment regardless of whether they were detected by active case finding and passive case finding, which may or may not be the case in practice. But for the time being, we've assumed that everyone who is diagnosed enters treatment. And finally, we're very cautious about our interpretation in terms of generalizability. This is kind of an urban, low HIV setting. Most of the areas, catchment areas for health centers where most of the patients would be living are very small in geographic area. So that's something that we have to keep in mind. But I think, and the NTP here is fairly stable in terms of its structure and its ability to perform on basic dots. So that's another consideration when we think about these types of endeavors, incorporating them into the NTP locally. So I'll thank my fellow co-investigators, both in Peru and in the Red de Salud de San Juan de Lurigancho. Pardon me? Oh, okay, thank you. Thank you.
Thank you. I appreciate that you had a lot to say and
yes.
a lot to report. One short question, please. Please identify yourself and use the microphone.
My name is Oriol Ramis, and I do most of my work defending active case finding. So my question, yes. Don't take it as a challenge to that. But one of the problems I have with those analyses is we don't know exactly how many of the cases we found in active case finding are cases that would have been missed anyway. So yes. The probability of a case that is found among active case finding that would have been able to find its way through, passive case finding is always a challenge. That in those studies, I don't know how you build that in your explanation.
Yeah, so I think you're very right. We don't know how much of those people would present. We did have some data from the previous years where there was sort of some capture. They would tell patients to come bring their household contacts. So we have some idea that it was lower than what would be an active case finding. So we've included that somewhat in our passive case finding figures for sensitivity analyses. But that's definitely a very challenging aspect of these analyses, yeah.
Thank you. Thank you very much. And the last speaker of our session this afternoon is Florian Marks, who is a postdoc fellow with the Yale School of Public Health in USA. Over to you.
Thank you very much. Good afternoon. It is my pleasure to share with you data from our modeling study on the impact of TB control interventions targeted to previously treated people. There's mounting evidence from Southern Africa on the high risk of tuberculosis amongst people with a history of previous tuberculosis. Those are some examples of studies. The risk is increased amongst people even after previous cure, treatment success, and even amongst HIV-negative people. And it was interesting today to see data from the household study in Peru, seeing that previous history of treatment even does matter amongst household contacts in the study as a risk factor for tuberculosis. And as one example, I want to share data from a study that we've recently published. This is data from prevalence surveys. It's a secondary analysis of prevalence survey data from 24 communities in Zambia and South Africa. And I think this figure shows, tells an important message. If you look to the left, if you look to the left, you see 24 communities, and we see on the Y scale the prevalence of culture-confirmed tuberculosis in these communities estimated in the survey, and then the proportion of the survey population that reported previous treatment. And we can see that in the communities with a very high prevalence of tuberculosis, between 10 and 15% of the entire adult population reported previous treatment. And on the right-hand side, we see estimates of prevalence stratified by previous treatment, treatment experienced in the black circles, and we see very high prevalence rates amongst people reporting previous treatment, between 3 and 5%. So what does this mean? That means if we were to screen them, then between 20 and 25 or 20 and 30 people, 1 in 30 people would be an active case of tuberculosis at the time the prevalence surveys were conducted. So very, very high prevalence rate. Now, the problem is looking at prevalence will not tell us something about transmission and the impact at the community level. So we decided to conduct to develop a mathematical model. And the idea was we wanted to project the impact of 2 hypothetical targeted interventions. The first intervention was finding recurrent tuberculosis earlier amongst people who completed an episode of TB treatment before. And the second is preventing recurrent tuberculosis through secondary preventive therapy. So that means people would complete their treatment and they would be allocated to isoniazid preventive therapy right after treatment. So we developed a transmission dynamic compartmental mathematical model of TB and HIV, and we calibrated this model to demographic and TB prevalence and TB program data from 2 high incidence communities in Cape Town. So we used a Bayesian calibration procedure which allowed us to use existing data from these communities to estimate parameters. So we used parameter ranges as priors, but we used the data to estimate parameters. The main outcome of our model was the TB incidence, prevalence, and mortality over a 10-year period. That means the number of TB cases and deaths that could be averted through the interventions. Just to show you the study setting, this is South Africa, the Western Cape Province, South Africa, Cape Town, the area of Cape Town, and the 2 communities shown here, Ravensmith and Eitzig, 2 communities with a population of about 39,000 people and about 350 to 400 tuberculosis cases notified per year. So that's a notification rate of about 1% of all forms of tuberculosis, so very high rates of tuberculosis. So I want to quickly walk you through the structure of our mathematical model. So our model follows the conventions of previous TB models. We have a structure, as we can see up there, of susceptible, latently infected, and infectious people. So the population is divided into these compartments, and then we estimate transition rates between these compartments. The upper part of the model shows people without prior TB treatment, and then we have 2 treatment compartments in the middle, TI and TC, representing that treatment was either complete or incomplete. We did not consider any other treatment failure or other outcomes of treatment. So this is a simplification. And then we allow people to walk through the model after treatment. We distinguish between people after incomplete and after complete treatment. And we allow people after treatment completion to be allocated to secondary IPT. This is on the right-hand side. And then finally, we have a second intervention, which is amongst people who are infectious again after complete treatment, and we applied active case finding here as an additional rate. We also have a relatively simple structure of HIV, co-infection and antiretroviral treatment in this model, and we also had a subcomponent for children, given that 20% of the notified TB cases occur amongst children. This is a slide that shows our calibration targets. We had various data, and in the interest of your time, I want to skip any further explanation, but we used a lot of data to calibrate our model. To present the key findings of our study, we projected, or the model projected, about 4,292 incident TB cases and 642 TB deaths in the period of 2016 to 2025. So the model projected that targeted active case finding only among people who completed treatment would avert 14% of incident TB cases and 20% of deaths occurring in 10 years in the entire population. And targeted active case finding combined with secondary IPT would avert 40% of incident TB cases and 41% of TB deaths occurring in 10 years. Now I must say this really requires aggressive rollout of these interventions, but those are the margins that we believe could be achieved, especially in a high incidence suburban setting, if it was possible to focus on about 10% or even less, maybe 8% of the population with a history of complete treatment. We see here our projections over time. We have no targeted intervention at the top, and then we have targeted active case finding in the middle, and the triangles represent targeted active case finding and secondary IPT. What we can see is that targeted active case finding alone had a higher impact on prevalence and mortality, lower impact on incidence, but combined with secondary IPT, there was a tremendous reduction that could have been achieved in the community, or could be achieved according to the model outputs. Conclusions: we believe that in a high TB incidence setting, targeting TB control interventions to previously treated people could accelerate declines in TB incidence and mortality, but we need to do further research to assess under which conditions these interventions could be successful. We're doing some cost-effectiveness analysis next, and so this will give us information about whether this strategy would actually be cost-effective. I want to acknowledge my advisors, Ted Cohen and Nolda Byers, and other colleagues involved, including my colleague and friend Reza Yezubi, who has contributed tremendously to this study, and our funders that have helped us to do this work. I want to close with saying a short statement about TB survivors. I think we've all been very impressed by people sharing their stories, TB survivors sharing their stories at the conference, and there are two things important. First of all, these people have done a tremendous service to communities by seeking and completing a long treatment, and I think we need to acknowledge that. They should not be stigmatized, but they should be lifted up, and I think it's worth remembering that. And the second thing is I think previously treated people represent a vulnerable group. They are at risk of tuberculosis. We know they are at risk of other lung diseases, including chronic obstructive pulmonary disease. They are at risk of being stigmatized, and they are at risk of poverty. The socioeconomic consequences for their families are important. So I think we should pay closer attention to this very important risk group. Thank you very much.
Thank you very much for your presentation, as well as the advocacy message at the end. I thoroughly agree with your message. We have time for one or two questions. Could you please come to the microphone, identify yourself, and pose your question? Perhaps, Knut, you want to start? And we give a chance to the second gentleman after you. Thank you.
Knut Launer from WHO Global TB Program. Thanks, Florian. Great presentation. And my question is about what do we know about the risk of TB if you're previously treated twice or 3 times? And have you factored into your models that what I would guess is the high risk of relapse if you have active case finding, for example, you have early treatment? Does it figure into the model? Do you see some kind of diminishing return for what I guess have to be repeated round of finding the same people over and over again?
Yes. Thank you very much, Knut. This is an excellent question. People have very often looked at it the other way. They've looked at the complications to lung disease after multiple episodes of treatment, but I know at least of one study that has looked at the consequences of lung impairment due to different previous episodes of tuberculosis, and this study suggests that there's an increased risk of tuberculosis by multiple episodes. And I think we've also done some early analysis on the data in this particular setting where we see that there's actually an increased risk of people of tuberculosis by multiple episodes. So if people have multiple episodes, they're at higher risk. And we do not really understand why this is the case. Is this because the lung is being distracted, and or are these people likely to go back multiple times to the same people and get exposed over again? But I would guess exactly that's the case. People are at higher risk if they had already multiple episodes. Yeah.
Thank you. And the last question for this afternoon's session.
Yeah, the name is Dr. Joseph Ajubewe from National Hospital, Abuja. Now, your study, did you define the TB? You say TB cases, 4,292 incident TB cases and 64 true TB deaths. Are they pulmonary TB or extrapulmonary?
Yes.
Or does your model include both? Thank you.
Yes, this is a very good question. We simplified that. We did not consider in our model pulmonary versus extrapulmonary tuberculosis. And I totally agree there's a difference. One should actually, in studies, one should look at the differences of different forms of tuberculosis in our mathematical model because it is already so complex. We did not distinguish between pulmonary and extrapulmonary TB.
Thank you very much. Thank you to the speakers, and thank you to you, audience, ladies and gentlemen. Enjoy the rest of the day.